Thank you very much for that kind and somewhat exaggerated introduction. I've been sort of backing away from practice, and I can't say that I've been giving my cell phone number to everybody recently, and soon I'll be ex-professor at the Medical College of Georgia, which is at Augusta University. So I was given the task of talking about Parkinson's disease, the past, the present, and the future, 30 years perspective, because I started the Parkinson's Clinic, which was the first clinic in Georgia, South Carolina, in 1985. So it's just over 30 years perspective. And I just want to introduce a couple of people. My two sons are here, Gaurav and Ajay, and Gaurav's wife, Heather. They live here in Greenville, and Ajay was just visiting, so I'm really happy they're here. Ajay is also going to advance my slides, so if there's any mistake, any problem, it's all him. It's not my problem. All right, let's get started. So we'll start with where the field was when I came in. I didn't come into a vacuum. There was a lot of work done before me, and that has to be recognized. And also, when you study history, you realize how slow the progress can be in treating anything. First, you have to have a good description, then you got to understand what might be causing it, and then you got to fix it. So we'll see that the progress has been very spotty and generally slow, but sometimes you're just surprised. It comes out of the blue, and that's the next one we are waiting for, something that comes out of the blue. And science just progresses like this, you know, it's going slow and suddenly you make a big leap. So let's see where we were. So back when 3,000 or so years ago in India, they had recognized an illness which they call shaking palsy, or kampwat. Kamp means shaking. And they did not know why, but this particular plant with beans, Mucuna pruriens, help these patients shaking and shuffling, and they were giving it just in the Ayurvedic medicine. And Mucuna pruriens is still available in a powder form for some of the organic, holistic kind of people. They don't want to take pills. You can actually take that powder, and it actually helps Parkinson's disease. The reason is that it contains levodopa, which is the gold standard medication for Parkinson's disease. And levodopa still remains the best drug, but it's been around for 3,000 years, and we didn't even know it. Next slide. And I'm going to bring you up to speed on another plant, which is very important because it helped us study Parkinson's disease. This is a Revolvia alkaloid named after a German botanist who in the 16th century went to India and brought it. And that time, Indians were using it to treat psychosis and snake bite for some reason. But psychosis, which is thought to be almost too much dopamine in certain parts of the brain, and this plant has been called Revolvia, but what you drive out of it is called belladonna. And belladonna is what all the anticholinergic drugs come from. So we will talk about this, and reserpine is one that depletes dopamine, which is different. Okay, next. But it's also mentioned in the Bible. In the Bible, they talked about when the guardians of the house tremble and the strong men are bent. And you can deduce yourself that this may have something to do with Parkinson's disease. And another description talked about someone crippled by a spirit, completely incapable of standing erect and bent forward. Some description that resembles Parkinson's disease. So it's not a new disease. I think it's been with us for a long, long time. The thing is, back in 2,000 years ago, most people did not live to be 70, 80, 90. And with the progress in science, with vaccinations and treatment of infectious illness, taking care of your cardiac problems, we are blessed to be able to live as long as we do, but we also curse because the rest of the field has not kept up. The brain is the last frontier, and at some point, when the brain cells getting so old with repeated different kind of toxic materials that you're exposed to, or internal metabolism, they get damaged and they just can't recover like a young brain can recover. A young person has a brain injury within weeks to months. They can recover. Brain is very plastic, and the plasticity goes on, but definitely reduces as you get older. So this is one of the price we paid for living as long as we are. But it has always been around with us. Next one. And that, so we've been on this earth, Homo sapiens, probably for 200,000 years. Before that were the Neanderthals and others. But 200,000 years. And only 200 years ago, somebody described a disease which we are dealing with. It's named after him. He was practicing in England. 1817, he described this illness that was characterized by involuntary tremulous motion, and so on and so forth. Tendency to walk with a shuffling gait, a tendency to start running almost. Sometimes Parkinson's patients have to stop themselves from running into a wall. They start to walk forward and they can't stop. And that's what he observed. And the disease is named after him, but it took about 60 years. Next slide. And this is another man who is important, and that was Charcot. Charcot, in 1861, named this disease Parkinson's disease. And then he used belladonna alkaloids. I misstated in the original Revulfia. Revulfia will come back in a second. He used belladonna alkaloids to treat drooling and tremor, and we still use Artane or trihexyphenidyl in right selected people to treat drooling and tremor. And now this was 1861. And 100 years were to pass before we had an effective treatment for Parkinson's disease. For 100 years, the mainstay of Parkinson's disease treatment was just these anticholinergics, which we don't employ because they have too many side effects. Next one. The person who named movement disorder, the field that we practice, his name is Stanley Fawn. And here I must recognize Dr. Freddie Revilla. I just see him standing in the back. He's I think you've been here a year or more. He's the Parkinson's specialist through 2 years. And I have followed his career since he was a fellow. He was always bright, and I was so happy when I heard he's coming to Greenville. Welcome. Have a seat if you want. Okay. So Stan Fawn, when he was teaching his residents, he said, in general, caring for PD patients is a rather hopeless task. This is early 60s, 100 years later. Now this man started the field, movement disorders, in which Parkinson's disease is one movement disorder. It just shows in 50 years ago, 60 years ago, things were deemed hopeless for Parkinson's patients. And we have many bad brothers of Mr. Parkinson right now, diseases that we really don't want anybody to have, but they share symptoms with Parkinson's. And I'm always relieved when I see somebody with Parkinson's-like symptoms that they don't have something in that family of diseases where we can't do anything. So that's where Parkinson's disease was in 1961. So all before I started. Next one. And then came along this man, Arvid Carlsson, a Swedish gentleman, scientist. He won a Nobel Prize in the year 2000 for what he did, and I was blessed enough to meet him and lecture with him in Europe a few years ago. And he started using a derivative of the old Revulfia alkaloid that came from India originally. He took that thing, and it was reserpine, which was the chemical. And next one. And what he did was, he took a normal rat. It started with rat and mice, then they tested it in rabbits and monkeys. Normal monkey, number one, that's normal monkey, alert, looking straight, bent, hunched over, expressionless, after he receives a lot of reserpine. Reserpine depletes the brain's dopamine, okay? The same monkey who hasn't been treated yet, number three, and that became a model for Parkinson's disease early on. It's not the best model, but it gave us the insight into how to treat Parkinson's. That same monkey who was Parkinsonian was given levodopa. which is still the gold standard. And that monkey is now alert, back looking normal. This is what gave the medical community an idea that levodopa could be used to treat the motor symptoms of Parkinson's disease. Next one. And then they started to use it, but people would throw up because levodopa gets converted into something, makes you vomit. They could never get to a big enough dose, and they were about to give up. 6 more, 7 more, 10 years passed, and nobody thought levodopa was going to work in Parkinson's. And then this Greek gentleman who lived in the US tried slow titration. He went higher and higher and higher till he reached a threshold of response. And he used grams and grams of levodopa. And he showed for the first time in 1967 and then in 69 that levodopa dramatically improves the motor symptoms of Parkinson's disease. I'm focusing on the motor symptoms right now because that's what Parkinson's was thought to be, a movement disorder only. It's a motor disease with tremor, rigidity, shuffling. You fix that, Parkinson's disease is cured. So everybody thought we have found a solution to Parkinson's disease. And what Kartsias taught us next. Next, please. Okay, let me show you the patient. Click if you can, go at the bottom. This is a patient who has been admitted to slowly titrate that levodopa, which was a miracle drug at that time. He was admitted in the hospital. Now you can't get admitted for a major surgery. Your HMO wouldn't pay for it. But those days they could admit patients to give medication, try different things, try physical therapy. He could barely walk. You see him, he's shaking. He has he's hunched forward. He can barely walk. And the nurses used to dress a lot better those days. Look at that. And he has to be supported to walk. Now this is what Parkinson's patients were like. India, when I was learning neurology back in the late 70s, many patients could not afford levodopa. Even now in sub-Saharan Africa, levodopa is not available in a majority of the countries. That should tell you how fortunate we are. Obviously, we pay a lot for it, but these Indian patients at that stage slowly went down. I had to go to their houses because they couldn't come to the hospital. And I saw them just go down, become rigid, stiff. And there was nothing we could do except watch hopelessly. And this man was lucky enough to be born in the era where levodopa had already been tested and was available to him. And you'll see him after levodopa. The tremor is pretty obvious. And you might hear that levodopa does not help tremor, but that's just not true. In a lot of cases it does, but tremor also can be quite resistant to treatment. And this gentleman, in a second, you'll see him after treatment. Ajay, on timeline, you can go a little more right, but use a mouse. Yeah, on treatment. Okay, here he is. Same person, outside the hospital, of course, dressed in normal clothes. He's going to get up, look how erect he is. He's going to walk. And this same kind of miraculous results we can reproduce today using an injection called apomorphine or apokin. Only works for 45 minutes, but you can see patients transform under your eyes from being totally stiff and rigid, and then they start to walk quite normally, in fact. Okay, next slide. So really, Dr. Kartsias taught us that you may feel that, the goal is within reach, but so hard to get there, but just do not quit. Once you decide something is worth trying, you want to keep patient, being patient. You can't just give up on potential treatments just too quick. And that's a tendency now for companies. They see there's no profit or there's no quick solution. They will give up on hundreds of compounds, and I think that's the practical nature of things. Next one. So this is levodopa. It came out. People were in wheelchair. Patients got up. They wanted their checkbook back. Wives were upset because they wanted to have sex again. They hadn't had sex for 2 years, 3 years. And L-Dopa was then sold as a aphrodisiac, on the streets. This is a real advertisement from one of the newspapers in LA at that time. So L-DOPA has many effects other than treating your movement problem. It also is a pleasure chemical. When you're on, you feel better, you feel life is good, and when you're off, you feel miserable, and you can't wait to be turned on. And that's where we were. L-DOPA was not only touted as a cure for Parkinson's, but it was also said to enhance your other powers. So this was a great drug. This was the era when everybody thought we have found solution to Parkinson's disease. But unfortunately, things are never that simple. And we are humbled repeatedly by this disease. Next one. So this patient was seen by a neurosurgeon in Augusta. She brought this bottle to me. And this bottle costed $500, and it was 1 kilogram of levodopa. So this is how they had to take levodopa. And then they developed another compound to make more of the levodopa go into the brain and not being destroyed in the periphery. That was carbidopa, and that levodopa-carbidopa combination became the mainstay of treatment. That's called Sinemet. Sin means without, emesis is vomiting. So this Sinemet reduced the risk of nausea and vomiting, which you used to get a lot with levodopa. All that is there when I joined the field in 1985. This happened in the late 60s and early 70s, all right? And then we started seeing patients having fluctuations. They started having off periods. They will wake up off, turn back on, and then they got slow again. Some of them started having abnormal movements, which some of you have experienced. Those are called dyskinesias. And there was a feeling in the field that levodopa may be doing something bad to the Parkinson's brain. Levodopa is toxic. And a lot of people started delaying this very effective therapy for fear of toxicity. And that was a period of uncertainty. Several studies showed that actually it is not so. I can't go through this whole graph. But basically, there was a study done giving different doses of levodopa and a sugar pill for 9 months and doing some scans and clinical assessment. It was shown that levodopa is not toxic. Because of its short half-life and other problems in the brain, the propensity to develop off-period dyskinesia has been a major issue. But maybe we can resolve that by giving this drug rather constantly. But there is no reason to delay levodopa in the right patient. And that thing has been a thing of the past. We went through an era where people delayed levodopa unnecessarily, and I'll come back to that in a second. Next one. So this is a patient was seen by me in 1990s. And this is a hand drawn by somebody in 1880. And this man was from rural Georgia, and for whatever reason, he never received levodopa. I saw him, I was able to help him, but he still had some fixed contracture, so the levodopa phobia actually dominated the field for a while. Next one. And some of it was driven by companies, and I'll come back to that. Now, just quickly, I want to, and this is too detailed for this particular talk, I want to say that, yes, levodopa here goes into the brain, makes dopamine. It acts on the dopamine receptors, and we develop drugs that directly act on the receptor. Those are called dopamine agonists, like ropinirole or Requip, pramipexole or Mirapex, Nupro, rotigotine, and apomorphine. There are also other drugs that help levodopa get into the brain and not be destroyed. Those are called COMT inhibitors. You probably have heard of Comtan or Tasmor or Stalevo. So these drugs, all they're trying to do is stimulate dopamine in some way. So we are still focused on the motor symptoms right now, okay? Because Parkinson's is far more complex. And that's what I'm going to come to in a minute. Next one. And so first drug that was used, and that was right in mid-70s before I came on the scene, was bromocriptine, Parlodel. Most of you have never heard of it. But this gentleman, Donald Kahn, he told me, he says, look, that's my picture. You can tell because he's playing golf in Taiwan. He says, I'm in the rough and I have no idea what I'm doing. He's pretty lousy golfer like most doctors are. I mean, lousy. But he was good at what he was doing. He developed bromocriptine, And now we have developed other drugs. Original agonists were ergot agonists. Next one. And ergots have a propensity to cause peripheral vasoconstriction. So you get tingling and sometimes to the point of blue fingers, and it's called Raynaud's phenomenon. And florid variety would be called ergotism. And this is a patient I saw with another ergot agonist. You see the hand on the top, bluish, purplish fingers. They could have been gangrenous if I didn't stop that drug. After a few weeks, she was perfectly normal. So ergot alkaloids were then abandoned. Now we don't, the drugs we have now are non-ergot dopamine agonists. Next one. And we did not realize that, yes, they delay dyskinesia, but they cause a lot of problems. One of them is excessive daytime sleepiness. And all of you know sleep is disrupted in Parkinson's. You are awake many times during the night, different reasons. But drugs, many drugs make that problem worse. Dopamine agonists cause so-called sleep attacks, some accidents, and we became very cautious in their use. Next one. Also, they call something called impulse control disorders. And every time I see a patient who is on a dopamine agonist, pramipexole or Mirapex, Nupro or Requip, it's imperative that I ask them about any impulse control disorders. These solid citizens who've never done anything like that start to gamble online, and some of them become hypersexual. Women generally start to shop a lot. They go shopping. And that can be very disruptive. And even now, I'm sure a third of you are on one of the drugs I'm talking about. But we didn't realize that at that point. We were giving a lot more dopamine agonists, delaying levodopa unnecessarily, thinking, oh, it's going to cause dyskinesia, it's going to cause problems. And we weren't treating our patients effectively for about 10 years, period. But after some studies, after understanding how frequent these side effects were, we have become wiser. And now we use levodopa whenever it is needed, except in very young people under the age of 40 or 45, which is 5 or 10% of the population in a specialty clinic. We would give levodopa as soon as we think it's necessary. So there's no reason to postpone levodopa. Next one. But it took a little while. And we were also trying to see if we can give a long-acting levodopa to delay dyskinesias. Nobody wants to be dancing around. And we did a study using a long-acting preparation. Unfortunately, it actually failed. We haven't found a drug, that levodopa preparation, that delays dyskinesia. Next one. We do have multiple new kinds of levodopa, and that's, as I said, is very important to develop long-acting levodopa. There are companies developing a skin patch, which will work constantly throughout the day. We already have a drug delivery system, which is called Duopa, where you put it in your stomach. You put a tube in the stomach, take it to the upper small bowel, and you drip this gel. It's only suitable for advanced patients who turn off all the time and have dyskinesia, but do not want deep brain stimulation. So there is a way to deliver levodopa constantly, but if we can do it in a non-invasive fashion, like by a patch, by a pill, even by an implant in the subcutaneous area, that will be the big thing, because levodopa helps motor symptoms, there is no doubt. It's just that the levels go up and down with every pill. Sometimes you absorb it, sometimes you don't absorb it. You take a lot of protein, like in a steak, you freeze up, levodopa doesn't work. And so we have to overcome those problems. It's been very difficult. Let's say it's been around since 1971. We still haven't got the ideal levodopa preparation. Next one. So this was for symptomatic treatment. And then during the time when I joined, I was lucky. I've been lucky all my life. I joined the Parkinson's field right when things were beginning to pick up. The movement disorders was not even a known field. Everybody was treating Parkinson's. There were no Parkinson's specialists. There were very few fellowship training patients to look after Parkinson's disease and other movement disorders. But right around this time, they started to see, can we slow down Parkinson's disease? They found that levodopa treats motor symptoms, but it doesn't slow down the Parkinson's disease. People still deteriorate. I don't have to tell you that. You have seen it. I've seen it with my own eyes over 30 years that this disease still progresses. And same is true if you have a deep brain stimulation. So we ideally need to stop it dead in the tracks. Some will say that means cure. Well, okay, maybe it won't make you normal, but if we can stop you where you were at the time of your diagnosis, that'll be a huge advance, that you had a little bit of shaking, a little bit of slowness, you can live with it. If you can slow this disease down, we can make a big difference. And that slowing disease, the process is called neuroprotection. There are many terms that are used, or disease modification. Next one. So we have been looking for a neuroprotective drug for a long time. Now, why can't we develop it? And there is a gentleman asking me this question, why can't we cure Parkinson's disease? Well, you know, I would be very happy to retire once I had fixed Parkinson's disease, because I've seen a lot of my friends, I've become friends with patients, and I've seen a lot of them deteriorate and die, and it's a tough field to be in. I'd rather go and take a wart, freeze a wart. I'll make you look pretty, I'll give you Botox. It'd be so much gratifying. You come every 3 months, I take care of your wrinkles. I mean, I'll be happy. I'll go home probably feeling very satisfied and with a lot of money in my pocket. Nobody pays cognitive specialties like they pay plastic surgeons. The family medicine, internal medicine, neurology, all these are kind of low on the totem pole. That's why the medical students don't want to go into neurology. They don't want to go into these other fields that don't pay a whole lot of money. The top fields are orthopedic, radiology, dermatology. I'm not complaining. I've been really blessed to look after patients with Parkinson's. And the drug companies, they don't have much of an incentive. Agreed, the first drug that cures Parkinson's or Alzheimer's would be the biggest blockbuster ever, yes. But the chances of that happening are very small. So they focus on diabetes, they focus on hypertension, they focus on reflux. You know, let's develop another purple pill and make a lot of money. So that's one problem. The companies are not interested. They are beginning to change their mind now. They see that there's a potential here. But how do we develop a drug? How does a drug get developed? The first thing is you get an animal model of the disease if you understand the disease process. Then you try some intervention in that animal model. Then you guesstimate a dose that you want to give to humans and bring it to trial, make sure it's safe. That's called phase 1 study. Volunteers, medical students typically given $1,000. They are volunteers. The medical students are young. We want to do phase 1 in older people, and that's not always done. And then go to some other studies, and the last one is phase 3. And then it goes to FDA for approval. Problem is we don't have a good model for Parkinson's disease. The other problem is that Parkinson's disease, right now as we know it, is wrong. Parkinson's disease, in that disease, there are probably 50 diseases. We can't separate out people yet. We don't have subtyping, way to subtype who has what type of Parkinson's disease. It's not one disease. And we're trying one intervention for 100 people who have 20, 30 types of different Parkinson's diseases. It's a problem. Thirdly, we don't know, so we don't have a model. We don't know what drug to use in the animal. Even if we start one, we don't know how much to use in humans, because most of us will agree that rats are not the same. And you can't test a lot of drugs on lots of monkeys. It's inhumane. So a lot of times this gets delayed, and it's estimated it takes about 15 years from the time you start testing a drug for it to come to the market. And it's been a challenge, but that has not stopped us. Next slide. And I won't go through all the list, but these are all the studies on neuroprotection that have been done since I joined the field 30 years ago. And they have all basically failed. That's very disheartening to say. We tried coenzyme Q10, we tried vitamin E, we tried other group of drugs, we tried creatine, we tried riluzole, and so on and so forth. However, next one, there is a, let's go next one. One more click, one more click, one more. Okay. there is a little evidence in favor of a group of drugs called MAOB inhibitors, selegiline or deprenyl, aldapril, or rasagiline or Azilect. Many studies have shown that if you use those drugs, they may have a small effect on disease progression. But they are not approved for this. It's not conclusive. And I really don't want to go to the whole design here, but 1 milligram rasagiline or Azilect a day was shown to be better if you start it early rather than if you delay it. But it's not conclusive. So unfortunately, right now we do not have a drug that slows down Parkinson's disease. What slows it down? Well, I think personally I believe exercise, mental and physical, the right attitude, staying active, taking the right combination of medications, and that's about it. And then, of course, some people are lucky. They have a slowly progressive form of Parkinson's disease, and we still don't understand why. Next one. Now, moving on, still sticking to the motor problems, okay? The non-motor issues, maybe the next 5 minutes. The surgery for Parkinson, it started before levodopa, 53. Surgery has been done for over 100 years. But June 53, the month and year of my birth, somebody had an accident while trying other surgery and damaged a certain part of the brain. His name was Cooper. And then he did hundreds of thousands of patients Parkinson's. He made holes in the brain. That was the old surgery, thalamotomy, pallidotomy, and a lot of my patients have gone through those procedures. But it was a French guy, surgeon named Benabid, who started to stimulate with rapid frequency stimulation to jam or stimulate certain circuits in the brain. And that has really helped a lot of our patients. Let's go next one. So this deep brain stimulation, it's a procedure where you put an electrode in your brain and you route a wire through the subcutaneous tissue and put it, there's a pulse maker here, a pulse generator that actually stimulates both sides of the brain. This has to be charged every other day, or battery has to be replaced every 5 years. It's right for the right patient. It's not for everybody. Next one. And click. So here's a man who has had deep brain stimulation. Here his stimulation is on. He came in the morning with no medication. So you see he's a little slow, but he doesn't have much of a tremor. So deep brain stimulation alone does not do everything. You still have need for medication in a lot of patients, although the dosages are reduced and the fluctuations go way down. So your day is a lot smoother, your night is a lot smoother. Here he is, we just turned off his stimulator. Look at that tremor. Sometimes, as I said, tremor does not respond to medication. So this is an indication for doing deep brain stimulation. Next one. Another one is click. Dyskinesia. You heard about dyskinesia. Many of you experience it. This man is the only man who thanked me for giving him the diagnosis of Parkinson's disease, because he had been told you have Lou Gehrig's disease, which is much more deadly. He came to me and I said, no, you have Parkinson's disease. And he says, thank you. But then he developed these dyskinesias on levodopa. We did the deep brain stimulation and his gait is just so much normal. Dyskinesias and tremor both are helped tremendously using deep brain stimulation. But many things are not. And that I'm going to come to in a second. So we still don't have an answer for Parkinson's disease. Next one. Multiple studies have done comparing different sites. I think it all depends on your neurologist and surgeon. You can choose globus pallidus or subthalamic nucleus stimulation. Next one. And so basically what happens before the surgery, before DBS, you have lots of fluctuations. Sometimes you get below a certain threshold, you're off, or you get dyskinesia. After surgery, the fluctuations become much less, and you do not turn off as much. But again, you have to be willing to have somebody drill holes into the skull, put the stimulators, and then go for programming repeatedly. And I'm hoping that the local Greenville Parkinson's department here is offering that procedure to you. Next one. Okay, but DBS does not slow down the progression of Parkinson's disease. It treats symptoms just like levodopa does. It treats levodopa complications, but it does not slow down Parkinson's disease. Next one. I talked about subtyping Parkinson's and different types of Parkinson's and developing a diagnostic test. When I joined the field in '85, studies were beginning to appear, next one, that out of 100 brains that were sent to a pathologist with the diagnosis of Parkinson's disease, only 3/4 of them had it. The other had something else. So we were not very good in diagnosing Parkinson's disease. We've become better. We're not perfect. Next one. And we have developed these functional scans to measure the dopamine system. Next one. And next one, just, oh, here, that's good. So here, if you see the top one, this is a DAT scan, which is commercially available. You'll see that normal healthy control has that red and yellow area in the basal ganglia. Parkinson's disease patients have asymmetric reduction. This scan is only done in selected patients in case you're not sure. But at least we have a way to measure dopamine system in the brain. For the first time, it's commercially available. Let's go to the next one. Routine MRI is not going to help you. Now, we also, around that time, that's what I said I was so lucky to come to the field around 1985. About '80s, there was this group of young addicts out of California who did a strange drug. They developed a drug which was a precursor to, they thought, heroin. They injected themselves and they became frozen. This was the case of the frozen addicts. This drug, illicit drug, was MPTP. And at that time, people were developing animal models using MPTP. You give these same patients levodopa, and they responded beautifully. But within months, they developed dyskinesias. They had severe Parkinsonian syndrome. MPTP then helped us develop animal models, which are not ideal, and it helps us test drugs for further development. Next one. We also, around mid-90s, found families with familial Parkinson's, which happens in about 10% of the cases, but we didn't know the gene. And the first gene was described in 1997. This was a Greek-Italian kindred, and they found synuclein. Remember this word, synuclein. You're going to hear about it for the rest of the talk. Because that opened up a whole new field of investigation. Next one. Now, we tried to figure out what causes Parkinson's. Around that time, we knew there's a genetic predisposition, and there is an environmental insult. At that time, pesticides got a lot of press, and living in rural areas, drinking well water was thought to be a risk for Parkinson's. They won't cause it alone. You have to be susceptible to it. Most of us will be okay, but some will get it. Next one. And at that point, we started to experiment with, look for more genes. Now we got multiple genes. One of the type is called Parkinsonism. Can occur at the age of 15, 20. The youngest I've seen started at the age of 9. It's a different type of Parkinson's disease, but later on they start to look just like Parkinson's disease. So both genetic and environment, we thought the interaction causes Parkinson's disease, or diseases, because there are multiple diseases. So once we had the treatment for motor symptoms, we thought we had sorted out Parkinson's disease. We were oversimplifying this complex disorder. And you know about it. Next one. Tremor, rigidity, slowness, probably a result of dopamine lack in certain parts of the brain. But that's just the tip of the iceberg. There's so many other areas involved in Parkinson's, and that's causing so many different problems in so many different systems. We just never appreciated that. It was only possible to appreciate it once we had treated the motor problems, because the patients were still complaining. I can't pee. I'm constipated. I get up, I get dizzy. I pass out. I see things. I'm sleepy. And then sometimes they get paranoid ideation. People are stealing from them. All that we just didn't know was part of Parkinson's disease. Next one. And they'll go to different specialists. They go to sleep doctor, they'll go to GI doctor for constipation or primary care, they go see another person for depression. Everybody would diagnose them for depression and give them treatment, but nobody put it all together. The blind man feeling an elephant, basically. And that concept, believe it or not, happened during my 30 years of practice. It just showed us how complex Parkinson's disease is. Next one. And we also know that this synuclein, remember the synuclein gene I talked about? That's what's deposited in a Parkinsonian brain. Not only in the brain, but also in your heart, also in your small bowel, the nerves that supply there. That's what causes constipation. It also deposited in nerves supplying the sweat gland. That what might cause excessive sweating or episodic sweating, and so on and so forth. And the synuclein is not confined to the motor areas. In more advanced stage, on the right, that pinkish purplish areas, they spread all over. That's when you start to have Parkinson's disease dementia. In fact, in dementia with Lewy bodies, same synuclein is accumulating, but the order may not be exactly the same, and there may be other factors. But Parkinson's disease progresses in an orderly fashion, in most cases, not everybody. You start with pre-motor problems like constipation, excessive daytime sleepiness, acting out your dreams, kicking and punching, called REM behavior disorder. Motor symptoms appear later. Next one. These non-motor problems include inability to smell. Olfaction can be impaired 15 years before you have Parkinson's disease. You could be sleepy for 10 years before you diagnose Parkinson's. So it's smoldering along. It's not a sudden fire that happened. We were diagnosed one day when we had tremor or slowness or shuffling. But it's too late. We are making the diagnosis way, way too late. I mean, imagine you go to cardiologist, you want the heart attack to be prevented. You do not want to have a heart attack, even if you have hypertension, diabetes. You want to take care of those risk factors. So the field can only progress if we can find Parkinson's before any tremor, any rigidity, any slowness comes. Next one. Okay, next. We also tried giving different types of cells and gene treatment. So far, there's one gene treatment called GAD gene, and now it's not being developed anymore, but it showed that clearly patients' motor symptoms respond. They're all still focused on motor symptoms. That's why they're not going anywhere, I think. Next one. Now, we also tried fetal cell transplantation. All that happened during my time. Fetal cell transplantation improve the dopamine system, the uptake as measured by scans, but clinically the effect is very variable. Younger patients get the response, but they get a lot of dyskinesia. So that procedure is not done anymore, partly because of ethical issues. You need fetal tissue, and not everybody can support that. And now we're trying to develop stem cell therapy, but I can't tell you that there's a promising stem cell therapy result that has come yet. But everybody asks me about stem cells, but it will happen one day. But again, you'll have to implant it in multiple parts of the brain. Because as I said, it's a diffuse disease. You can't put stem cell in one area and hope for it to spread all over the brain. Next one. Now, what about the future? And you know, obviously nothing I've said here is not known to you. You have seen the Parkinson's disease progress. You see the non-motor problems, you complain about them, you get medications for them. But what about the future? Well, I don't know. I have no idea what's in the future. Is cure going to happen in my lifetime? I don't know. Is it going to happen in your lifetime? I have no idea. I would hope so, but I've been hoping for a long time, just like you have. But I think we are making progress now, and you heard that before as well. Since the synuclein, we have been able to develop models for Parkinson's disease for the first time. None of the other ones, reserpine, MPTP, were good enough. The other thing we have learned, and I'll go over that, remember the fetal cell transplant that we did into the brains of Parkinson's patients? A few of them died, and we looked at the fetal cells that we transplanted. Next one. Keep going. Keep going. This is the fetal transplant study, next one. And right around that time when they were planning the studies, one of the guys was Langston and the other man, Bjorklund, they were sitting around and say, well, if we can put fetal cells in those MPTP patients who did a drug that damaged their cells, there's no more drug in their body, their brain is damaged, but we can put fetal cells and maybe they'll function. But what about a Parkinson's brain? Why did the dopamine cells die in the first place? If we put these fetal cells in there, is there something toxic in the brain environment that these fetal cells will be damaged? This was a worry that we didn't know the answer to. Next one. And unfortunately, in the last 10 years or so, we have realized that when you implant fetal cells, they make connections, there's no doubt about it. But over time, they develop the same Lewy bodies that occur in the host cells, the Parkinson's brain. So there seems to be something in the Parkinson's brain that, in fact, in a way, infects the fetal cells with whatever the process it is. And they accumulate synuclein. They start to look like an aged Parkinson's dopamine cell. These were fetal cells. And within 5 to 7 years, they begin to look like they are 80 years old. There's something in the Parkinson's brain that's infecting these people. Next one. And that brought this hypothesis, which is called prion hypothesis. There are certain diseases of the nervous system, they're very rare, thank God, where your own proteins change and start to damage other cells. They go from one cell to the other cell. Same process repeats. The cell bursts. They go into the intracellular, extracellular space, go back into another cell, and they actually infect other cells. This is called prion-like spread. This synuclein seems to be spreading maybe from the bowel up. Maybe the Parkinson disease starts in the bowel. We eat something. It damages it, makes a protein, changes the protein, that then spreads back up the nerve, just like tetanus does, and infects your other cells and so on and so forth. Olfaction, do we inhale something? Is that what's causing that first change with inhalation, with olfactory problems? We don't know that yet. But what it has helped us, next one, is to create models. We take mutated or abnormal, misfolded synuclein and put it in a monkey brain. Okay, just a normal marmoset. Next one. And these experiments have been done. You put in a small area of the brain, and then several months later, you sacrifice the monkey. And you see that this synuclein now has spread to multiple brain areas. There is something that's spreading gradually over the years, for many years before you get any symptoms of Parkinson's disease. Next one. Just keep one more. So, the synuclein, when the cell is damaged, it's released into the extracellular fluid. Normally it will be cleared by certain cells, but you could probably introduce substances that bind that synuclein and stop it from infecting other cells. And those are the immunotherapy treatments. Immune system treatment now is the new hot area of research in Parkinson's. Next one. And there are vaccines that are being developed to treat Parkinson's. I think the ideal time to give those vaccines would be in the pre-motor stage, when you're just having symptoms like REM behavior disorder, constipation, you get a DAT scan, your DAT is abnormal. We are going to start calling that Parkinson's disease. Right now, we do not label anybody with Parkinson's till they have tremor, stiffness, slowness, shuffling, and so on and so forth. You'll go to the doctor in the future. They'll ask you a checklist, and they find out if you're having any of the risk factors for Parkinson's. You will then go get a DAT scan that I showed you those images, and they'll show us subclinical reduction. It takes about 60–70% of the dopamine system to be damaged before you have any tremor. But what about if you catch it earlier than that and you intervene with these vaccine or other treatments to prevent synuclein spread in the future? That would be the biggest advance. So here are my predictions, and I don't know if I'm going to be around to see those. come correct or not, the definition of PD will change. We will include prodromal non-motor Parkinson's disease. So Parkinson's right now is a motor problem. We have spent all the energy treating motor problems. That will change. We just like in cancer, they have swabs every year, pap smear, mammograms, coronary artery disease. We do the risk factor and prevent the coronary artery disease. We'll do the same in Parkinson's disease. The most important thing, I think, is to then subdivide. Once you had Parkinson's, to be able to develop biomarkers, other means to subdivide. So you have type 14, or you have whatever names we give it. You will have your own Parkinson's disease category. And all the trials will be done in that group of individuals with defined drugs. That will come, but it's going to be a long time before we get there. We will do CSF or tissue serum. Biopsy is already being done in living Parkinson's patients in the submandibular glands, and you can find those same synuclein deposits in your submandibular gland. Some studies show it's in your skin. Others have shown it's in your in your bowel, in your colon. We're not sure exactly which one will then become a screening method, but eventually we will get there. We may be able to look at a patient who has a REM behavior disorder, kicking, punching in sleep, also constipation, anosmia. We say, okay, go get this biopsy. Once something gold standard is developed, we'll be able to diagnose Parkinson's disease before any tremor or rigidity. And so the therapy will be guided or geared towards individual based on their subtype. Next one. And I talked about interventions targeting synuclein accumulations, and we will be looking at different gene mutations, trying different drugs for different groups. The deep brain stimulation will become less invasive. Perhaps newer techniques will give you more control when you want to trigger deep brain stimulation. The other techniques that I don't even know yet would come, and that will help us. In a given disorder, if there's a gene mutation, maybe treating that particular gene mutation would be a great thing. We know that with some metabolic diseases like Gaucher's and Pompe's and others, there are some other types of treatments that could be given to individual patients. And of course, we are just beginning to study stem cells in humans. Several countries, they're doing some trials. I'm not aware of anybody doing a large-scale trial in the US, but eventually it will happen, and maybe stem cells will be suitable for some patients. Next one. And lastly, cocktail therapies. And I'm not talking about your gin and tonic or something like that. In other fields like tuberculosis, cancer, the success has been achieved by combining multiple drugs, acting at multiple different pathways. And you just hope to hit it by chance. In Parkinson's disease, all the neuroprotective studies, with one exception that use vitamin E and a MAOB inhibitor, they've only been done with one drug at a time. And it's very hard to do these trials in the US because of legal restrictions, FDA restrictions. I suspect these will come from elsewhere. I proposed a cocktail therapy trial with 3 different drugs for India, and I applied to Michael J. Fox Foundation. We were unable to get funding, but I think in the future, we will be using multiple drugs or combinations, safe combinations, to actually target Parkinson's disease. Before we can subtype everybody, maybe give everyone 2 or 3 different compounds and hope that one will hit the target. That's probably much better than trying one little drug at a time. Next one. And I hope it was not too long and too boring, but I am 30th June, I'm retiring, only to come back half a day, a couple of weeks, to continue some of the teaching. And as I see, I'm taking the plunge, but I don't know how I'll feel. I'll let you know next time I'm here. Thank you very much, and I've got time for questions. I think others will like to hear too. I'm sure that this will be definitely understood, and it goes beyond dopaminergic cells. That's one thing to remember. The depression in Parkinson's is probably related to serotonin cells. The REM behavior disorder may involve the norepinephrine system. So it's not a disease of the dopamine system at all. That's what our fault has been, just calling it a dopaminergic disease. It's not. But certainly some cells may be more susceptible to the others. And my son there probably knows immunology better than I do, but because this is all very modern, you have the synuclein, it'll be then recognized by a cell surface receptor, and these antibodies we give from outside or other substances will bind to the synuclein before it gets into the cell. I don't understand exactly the mechanism, but that's a good question. But it's many cells. It's not just dopaminergic cells. That's the important thing to remember. The dopamine-centric view has held us back. It has not helped propagate the field forward. It's not a dopamine disease only. I mean, there is no artificial age cutoff. We just have to meet certain criteria, which include not having many cognitive issues, no dementia. You probably have to be tried on medication and they cause side effects or fail to help you. Those are the only people that are going to get deep brain stimulation. Surgeons usually stop around 75, but I mean, obviously, if you have a tremor predominant patient who's otherwise doing great, we've done deep brain stimulation for essential tremor over the age of 80, and there's no reason why we can't extend it, but it would not be something that will be offered as a first-line treatment. I think medications, combination of physical therapy, medications would probably be the best option for you. They're trying deep brain stimulation as the first treatment in France in a very young group of individuals, say 40s, early 40s, low 50s, maybe earlier. That's when they are doing it, before they get medications. And there is a tendency to do it earlier in the course, but not at the time of diagnosis. I think everybody agrees that first we try medication. Some patients do well on combination of medications for 10, 15, 20 years. They get problems, but deep brain stimulation itself has issues with operative morbidity, mortality. Then you have a hardware, software, you have to stimulate, you get infections, you have to replace the battery. And so I think that maybe in a younger patients, where the life expectancy probably another 35, 40 years, that may become an option. But I suspect at your age, it'll only be done if the medications are not doing the trick. And it's unlikely a surgeon would do it without really considering everything. The French connection. The question is the French connection. One was I was talking about this study they are doing with deep brain stimulation in younger patients. Many of them even before they got any medication or within the first year of diagnosis. There was the French neurosurgeon in 1993, I think, his name is Benabid. He started the deep brain stimulation field. So that's the other French connection. The last French connection is Charcot, 1861. He gave that belladonna or Artane-like drugs to treat tremor and drooling. So I mentioned France 3 times. Yes, sir. Third time I will tell you, they call this tremor bread crumbling tremor. They don't call it pill rolling. Everything to French is wine and food. So bread crumbling tremor. It's called bread crumbling tremor. Yeah.
Medical marijuana.
Ah, okay. I was expecting this question of medical marijuana. There are 2 different types of things that people are using, my patients are using. One is cannabidiol, cannabis oil, which is actually hemp oil. There's cannabinoids in there. There's no THC. And then there is the actual marijuana. So I have been able to, tell them you can use this cannabinoid. Some people say it works wonders. There's a trial going on University of Alabama, Birmingham, on the one without the THC. Now, there are other patients who come to me and they want me to give them prescription for medical marijuana. And in Georgia, it's not legal, but the governor, in his infinite wisdom, announced that Parkinson's is one disease where if you're caught possessing a small amount of cannabis oil, I think with THC, that you won't be prosecuted. And I've been trying to get on the list, and they said you're on the wait list, because there are other diseases like cancer, children with seizures, and Lou Gehrig's. And I don't know how they selected doctors. But other patients who take it, I mean, I don't ask them where they got it from, that they feel calmer, their dyskinesias are better, some patients, their tremor settles down, they think it improves their quality of life, and they continue to do it. And I'm not against it at all. I've got nothing moral against marijuana. It's actually probably less harmful at a certain age. A younger age, it's very harmful. But at a certain age, it's probably less harmful than alcohol abuse. And many states now, as you know, the federal government hasn't approved it, but many states, mostly in the West, it's not only approved for medical use, it's approved for recreational use. So it'll come around. I think the will come around and it'll be available. But I can't say there's a scientific study in Parkinson's showing that it'll make a huge difference in the long-term course. Certainly patients have told me they feel better, they're calmer. And the first lady that asked me for it is an 88-year-old German lady. I just want to feel better, she said. I said, I have nothing against you feeling better. She's not going to abuse that drug. I mean, she's 88, she's never abused any drugs. I was shocked when she asked for it. I said, why do you want to use it? She says, I just want to feel better. I mean, how can I say no to that? But I can't get her part. I cannot. I would love to. Okay, thank you very much, Pat. Thank you.
Thank you so much for being here, and we want to offer you this plaque, an appreciation. This is a Lifetime Contribution Award. Obviously, you spent a great deal of time working with this whole community, and so we wish you the best in your retirement.
Thank you. I've been blessed.
Thank you very much.
Where's the picture?
Yes, she is. She's coming.